Welcome to Module 3. This week we will continue our focus on maintenance of the periodontal patient from the material presented in Chapter 30 in your assigned textbook.
Periodontal maintenance is a continuum of professional care following surgical or non-surgical therapy and only applies to patients who have undergone periodontal therapies. The term is not used for healthy patients or patients treated for various types of gingivitis. Periodontitis can reoccur without maintenance procedures, and the goal of these procedures is to prevent a recurrence. Success of periodontal treatment can be determined without continuous periodontal maintenance. This is documented in literature and supports evidence-based dentistry. Take a moment to study this chart. It illustrates the importance of periodontal maintenance, but identifying an increase in attachment loss when the procedure is not performed. Periodontitis and perio maintenance go hand in hand when treating chronic recurring disease. The disease has no cure and cannot be controlled without therapy. This disease is controllable in a vast majority of patients who seek professional care and are compliant with the recommendations of their dental hygienist and dentist. The objectives for perio maintenance is the control of tissue inflammation caused by etiologic factors, professional removal of biofilm and calculus, correction of faulty restorative dentistry, elimination of smoking, and the control of systemic conditions as diabetes aid in the control of periodontal disease and the success of periodontal treatment. Stabilizing and preserving the attachment levels and alveolar bone levels is the goal for periodontal maintenance. Maintaining the dentition throughout a lifetime is the long-term goals of periodontal care. Take a moment to study this concept map of the procedures involved in periodontal therapy. Periodontal assessment is followed by non-surgical periodontal therapy and reevaluation. If disease is uncontrolled by non-invasive treatment, options to care are assessed. Periodontal maintenance remains the procedure of choice in monitoring periodontal disease. Periodontal maintenance is a team effort between the patient and hygienist. Patient must maintain meticulous self-care and adhere to recommended periodontal maintenance care. The dental hygienist must provide high-quality professional care that promotes proper periodontal maintenance care intervals and renews patient motivation through instructions in self-care techniques that will eliminate or reduce the risk factors of periodontal disease. Clinical exams during periodontal maintenance appointments includes the thorough clinical assessment. These procedures are required at every appointment. Results are compared with baseline clinical data gathered during periodontal probing procedures, oral health assessments, and radiographic exposures. Steps in periodontal maintenance examinations include the following: 1. Extraoral and intraoral examination. 2. Dental materials examination. 3. Radiographic examination. 4. Periodontal assessment. 5. Evaluation of effectiveness of patient self-care. 6. Identification of treatment needs. 7. Periodontal instrumentation. 8. Patient nutritional counseling. And 9. Application of fluorides. The periodontal maintenance examination includes the following procedures that must be performed at each and every appointment, and documented in patient's record. 1. Probing depths with progressions noted at 2 mm inquiries. 2. Bleeding on probing that is visible within 10 seconds after gentle probing. Sites are charted that require more attention with instrumentation. 3. Attachment levels with progression noted at 2 mm increases, and compared to prior documentation. 4. Tooth mobility noted to identified stability or increase in mobility. 5. Furcation involvement. 6. Mucogingival involvement. And 7. Gingival plaque levels. The self-care evaluation must be performed at each and every appointment, and documented in patient's record. This includes the following procedures. 1. Plaque scores to reveal the patient's level of self-care. 2. Documentation to record the patient's motivation to sustain good self-care. Hygienist must be a cheerleader for oral care as they simplify regimens for better compliance, and suggest alternative techniques for improvement. And 3. Assess patient's progress and performance, and inform the patient of their assessment. Failure to inform or motivate the patient may be perceived as disinterest, and therefore have a negative impact on future maintenance procedures. The periodontal instrumentation must be performed at each and every appointment, and documented in patient's record. This includes the following procedures. 1. Thorough plaque, biofilm and calculus removal. 2. Attention to the conservation of root surfaces during periodontal instrumentation. 3. Utilization of only the best instruments suited for the job, as ultra-thin ultrasonic precision tips, that are designed to create the least amount of damage on root surfaces. And curettes. Plastic curettes are also effective for deplaquing of areas. Patient counseling should be performed in such a manner that an interest in the betterment of the patient is clearly expressed. Failure to provide information may be perceived as disinterest. Most all patients need reinforcement and motivation, especially when addressing smoke cessation, risk factors associated to home care, medications or social habits, and nutritional counseling. The routine application of fluoride is intended to promote remineralization, prevent root caries, control dentinal hypersensitivity, and increase antimicrobial properties by decreasing plaque biofilm. Patients treated for mild, chronic periodontitis or moderate chronic periodontitis are required to alternate visits between general dental practice and periodontitis. Severe chronic and aggressive periodontitis patients should be maintained in a periodontal practice. Frequency of visits are individualized for the patient during periodontal maintenance intervals. 3 months is most common for the removal of subgingival pathogens. These levels rise in 9 to 11 weeks post-treatment. Less attachment loss and tooth loss with shorter intervals is documented in the literature and supports evidence-based dentistry. Determining factors for interval maintenance appointments are determined by the following. 1. Severity of disease. 2. Patient's self-care effectiveness, and 3. Host response from systemic or genetic factors, which would shorten intervals for the diabetics and autoimmune patients and smokers. Identifying retreatment causes must include the assessment of self-care habits, maintenance intervals, instrumentation, and systemic factors. Treatment options can include localized instrumentation, localized antimicrobial agent administration, and localized or generalized surgical procedures. Patient treated successfully for periodontitis and disease reoccurs will present with additional attachment loss, either generalized or site-specific. The most common site is in furcation areas. Clinical signs for reoccurrence of periodontal disease is progressive attachment loss, deepening pockets, bleeding upon probing, presence of exudate, radiographic evidence, and increased tooth mobility. Reasons for reoccurrence may include inadequate self-care, inadequate scaling and root planning, failure to control systemic factors, occlusal traumas, improper surgical techniques, treatment performed under poor prognosis, and refractory periodontitis that is resistant to treatment. Referring patient to a periodontist is the recommended procedure. Patient compliance behaviors coincide with medical and health advice. Some patients faithfully adhere to recommendations and follows the strict program of maintenance intervals given to them. The chart illustrates the recommended guidelines for non-surgical care of regenerated periodontal sites. Take a moment to read this chart thoroughly. The non-compliant patient must be approached differently, as motivation is a different process for each patient. Reasons for non-compliance may be fear of dental treatment, expense of dental treatment, low priority, competing demands on patients' time or financial resources, denies they have a problem, failure to understand the severity or the implications of their actions, or perceives indifference on dental health care workers. To improve patient compliance, provide printed self-care instructions and simplify your recommendations by limiting self-care aids. Seek out patient concerns and accommodate their needs by informing and counseling them on the specifics of their disease. Monitor missed appointments and provide positive feedback when possible. Identify areas of improvement, compliment them in front of the dentist, use positive reinforcement to convey a motivational message and limit criticisms. Remember to be truthful on their condition at all times, even though you are providing them feedback. Take a moment to review this concept map. There are many steps in improving patient compliance. Understanding the strategies and approaching the patient in a proper manner will be steps to successful implementation. Vary your approach as needed, provide positive feedback by complimenting your patient, provide the patient with printed materials, simplify the self-care process by limiting the number of aids and consider alternative to flaws if you are noticing a lack of compliance. Allow for open-ended questions during your discussions and seek out what concerns your patient. Remember to send reminders for upcoming appointments and follow up on any missed appointment. This will help to maintain periodontal intervals as necessary. Common problems for periodontal maintenance patients are related to age. 50% of the patients are affected by 50 years of age and 70% by age 60. Occurrences determined by 1. Attachment loss, 2. Inadequate oral hygiene, 3. Cariogenic diet, 4. Infrequent dental visits, 5. Past caries experience, 6. Inadequate saliva flow, 7. Lack of fluoride exposure, and 8. Removable partial denture. During caries detection examinations, for periodontally involved patients, it is important to assess exposed root surfaces due to attachment loss. Shallow, softened area on the root surfaces will appear leather-like in consistency. Newer lesions appear yellow to light brown, while older lesions appear brown to black. The location of may begin at or slightly coronal to the free gingival margin and spreads laterally and circumferentially around the tooth. No specific organism has been identified as the cause of root caries, therefore the etiology is unknown. A mix of bacterial population as mutant Streptococci, Lactobacillus, and Actinomyces are known causes. Demineralization occurs at a pH of 6.2 to 6.7. Root surfaces are more vulnerable than enamel. Mineral loss is 2.5 times greater than enamel. In the prevention of root caries caused by periodontitis, remineralization is necessary. Fluoridated drinking water, the use of 1100 ppm sodium fluoride toothpaste, mouth rinses containing 0.05% sodium fluoride, professional application of 1.23% acetylated phosphate fluoride and the application of fluoride varnish every 3 months are all recommended treatment options for remineralization. Antimicrobial rinses and supplemental therapies for periodontal maintenance is prescribed on a needed basis. Chlorhexidine is an antiseptic and antimicrobial oral rinse. It provides protection against a wide range of bacteria. It kills bacteria by binding to bacteria cell walls. The FDA approved chlorhexidine in August 1986. Chlorhexidine gluconate is available in a 12% concentration as an oral rinse solution. Xylitol is a naturally occurring substance. Manufacturers of xylitol market it as derived from xylem, which is found in the fibers of many plants including berries, oats, beets, sugarcane and birch. Commercially available xylitol is produced by the industrialized process of sugar hydrogenation. A catalyst is needed, and in the case of xylitol, Raney nickel is used, which is a powdered nickel aluminum alloy. There is currently no literature on any detrimental health effects of consuming hydrogenated sugar. It is important to note that hydrogenated fats and oils were used for many years before the very damaging effects to health became widely known. given the violent industrialized process that is required to produce a hydrogenated sugar like xylitol, it would seem wise to avoid based on the very poor track record of hydrogenated foods. Casein phosphopeptides amorphous calcium phosphate has been proposed to have antichoriogenic properties. Phosphopeptides of casein are produced from the tryptic digest of milk protein casein by aggregation with calcium and phosphate. K-phosphopeptide is a sticky protein that binds and stabilizes calcium and phosphate ions in an amorphous state. It readily binds to saliva pellicle, plaque, soft tissues and even to the hydroxyapatite component of enamel, and maintains saturation of levels of minerals, especially calcium and phosphate, at the tooth surface, thereby depressing demineralization and enhancing remineralization. It is a highly effective means of treating active caries prevention in patients susceptible to dental caries. Caries risk management is not a common practice for periodontal patients. Due to the nature of the pH of the oral cavity, most periodontal patients do not experience high levels of caries. Using the Caries Risk Assessment Matrix, caries are categorized by low, moderate, high, and extreme. If the periodontal patient presents as a caries risk patient, assessing their medication and diet will be necessary. Pathological factors, including acidogenic bacteria, salivary dysfunction, and dietary carbohydrates are related to caries progression. Protective factors, which include antibacterials, salivary calcium, phosphate and proteins, salivary flow, and fluoride in saliva can balance, prevent or reverse dental caries through a process of remineralization. Remineralization is a natural and reliable repair mechanism for non-cavitated carious lesions. If pathological factors prevail, caries progresses. If protective factors prevail, the caries process is halted or reversed. Low-risk patients are typically not considered periodontal patients. Recommendations include fluoridated toothpaste twice daily and professional fluoride applications. Moderate-risk patients' recommendations include fluoride toothpaste twice daily, sodium fluoride mouth rinses, fluoride varnish applications at maintenance appointments, and bacterial and salivary tests are optional and left to the discretion of the clinician or patient. High-risk patients' determination is supported by the following conditions: visible cavities, radiographic penetration of the dentin, radiographic interproximal enamel lesions, white spots on smooth surfaces, and restorations in the last 3 years. Recommendations include prescriptions sodium fluoride toothpaste twice daily, fluoride varnish applications at 3-month intervals, and bacterial and salivary tests to monitor changes in the oral cavity that would signal a needed change in home care or prescribed treatment options. Patients considered to be an extreme risk are determined by the following: a severe salivary gland hypofunction of less than 0.5 milliliters per minute, visible caries, radiographic images illustrating penetration of the dentin and interproximal enamel lesions, white spots on smooth enamel surfaces, and striations performed within the last 3 years. Recommendations for these types of patients include prescription 1.1% sodium fluoride toothpaste to be used twice daily, fluoride varnish applications at 3-month intervals, routine bacterial and salivary tests, baking soda rinses, 0.5% sodium fluoride rinses, and calcium phosphate containing toothpastes.
This week's discussion board topic will be of your own choosing from case 2 or 3 on page 572 in your textbook. Post your response to the discussion board with a 100-word posting by Wednesday midnight. Respond to one of your peers' discussion postings with a 100-word response by Sunday midnight. Make sure to respond to a peer's posting that is unlike your own. Completed the 15-minute Module 3 quiz and start gathering information about your position paper. You should have selected 2 articles from the library by this time. Complete assignment 2 of your professional portfolio. This includes listing your contact information, education, and certifications. The link to the professional portfolio building site is located in your syllabus and on the agenda page for this module. This concludes the audio lecture for Module 3.